going to get into a few NUROWN questions, and I know a lot of the audience is chomping at the bit to hear some of your answers. So we start by telling you we know that you are PI and that you can't release some data, and that you have to be circumspect about that. But we also know that the trial hasn't been unblinded to the PIs and patients as to who was on NUROWN and who wasn't. So just in your 40 years or so of experience, did you observe any treatment effect in any of the patients that you had that were participating in the trial?
Well, I mean, there are one or two patients who are sort of legendary, and I won't call them out by name now, but I see at least one of them smiling. And so there are some exceptional number of folks who've had a very dramatic response. And so there are some exceptional number of folks who've had a very dramatic response. The problem is that representative of the group as a whole? That's the question.
Sure.
And when all the data are broken down, we'll know the answer. I do think, I'll repeat, I think there is a benefit from the stem cell therapy. I'll repeat, I think there is a benefit from the stem cell therapy. The question is, when do you have to give it? How big is the benefit? What does it mean in terms of translating into widespread use? I think they have a benefit. I have several reasons for wanting to say that.
Talking about how could NUROWN modify neurodegeneration, neuroinflammation, and neuroprotection, and yet not have relevant clinical effect. So how does that make sense for our audience to understand?
Well, the question is it adequate intervention in each of those realms to make it the overall clinical course is in some way the integration, the composite of each of these events that are adverse and are occurring simultaneously. And the question is, which is most important, and how big is the effect of any intervention, not just stem cells, on each of those components? And what do we really need to do to get the Achilles heel of the disease?
Some of the people have said, we think NUROWN is going to need a second double-blind placebo trial to follow up on this. And so given what you've seen, do you think it'd be ethical to do another double-blind placebo when we know that there's some people that have already been responders?
Yeah, well, I mean, the question is, if the company feels it wants to shore up the results in some way that defines how best to give it and who best to receive it, in theory, that might require another study. Now, the question of how long you can do a placebo for is a big challenge. To ask people to go a year without being treated is really a huge ask. And, I have trouble as a clinician with that, and I'm not sure I would participate in a study again where there was a placebo trial that long. Most of the new studies, and all this, are like 6 months placebo. And most of them guarantee drug at the end, no matter what. So there are some ways to think about making it more plausible to do more trials. But a year of placebo is a big, big, big ask. That's a huge thing to ask of anyone.
I think the community agrees with you on that. So, Sarah?
Absolutely. This kind of goes back to the people in the NUROWN trial. I know there were some that had ALS FRS scores that were 25 or below. And we know that this might have convoluted the data a bit. How does this make it difficult for approval?
Well, you've basically said exactly the situation. The question is, what population of people respond, and how good is that response? And is it good enough to justify general approval or only approval for that particular group that responded? These are great questions, and they're pretty generic. And I certainly don't have the answers to them. Radicava is an interesting talking point because it came, first of all, from outside the US. Secondly, not everyone responded to Radicava. It was a subset of folks, and yet they got approval for use across the board. And I would think it's very, very hard to get an ALS drug approved just for a subset of ALS patients. It's one thing if it's a specific mutation. Okay, that's one thing. But if you're going to take all, say, sporadic ALS and only treat people who are at a certain stage of the illness and not others, it seems to me that's a very fine hair to split. That'd be very hard to do, I would think. My own view is it ought to be all or none. But if it takes more study to understand exactly how best to use it, the company will adjudicate that.
Question comes from the chat. It's kind of talking about biomarkers. I know we are currently doing research into speech and voice as a biomarker. And the question is, how long do you think until ALS has a significant enough biomarker that A, for diagnostics, and B, for maybe placebos in clinical trials?
Oh, I think they're there now. I think there's some very good biomarkers. The ones that I'm sure you've heard the most about are markers of neurofilament breakdown, so-called neurofilament heavy chain, light chain. Some of those are just almost as good in the blood as in spinal fluid. So I think they're there. Now, we probably need more. Those are markers of breakdown of neurons. There are other markers which tell you how much inflammation there is. And so we probably need those as well. And there may yet be other types we need, but I think you will find most of the studies that are being done now do incorporate the degenerative, that is to say, the neurofilament biomarkers. I don't know if that answers your question, but I mean, as we all know, the real promise of biomarkers is that if they're really good, they may show you benefit long before a clinical trial shows you benefit. Wouldn't it be nice if you could do a study in 6 weeks? Forget a year of placebo, just say 6 weeks, 2 months. And that may happen. That may happen.